All right. Thank you all for being here. If we haven't met, my name is LoyalTillotson. And for my 909 project, I looked at the impact of social determinants of health on cancer screening rates in the contiguous US. And I chose this project based on some work I've been doing with a few professors on campus, Dr. Chris Seagren from the communication department and Dr. Megan Skipa from the nursing department. And we've been conducting research on how neighborhood characteristics influence health and well-being. And so this project kind of stemmed from that. So for this project, I looked at 3 types of cancer screening or types of cancers. And so I'll start by sharing some stats about these. These pairs of bars on the left are new cases, rates of incidence rates. And on the right are mortality rates across the last 3 decades. And as you can see for breast cancer, the incidence rate has stayed fairly steady over the past 30 years or so, while the mortality rate has decreased each decade. For cervical cancer, both the incidence rate and mortality rate have decreased each decade, and the same for colon cancer screening as well, or colon cancer. So this shows that in the case of breast cancer, treatment has clearly become more effective, while screening maybe not so much. But for cervical and colon cancer screening, or for cervical and colon cancer, both the screening and treatment have become more effective, it seems. However, it should be noted that even if screening is not necessarily reducing the number of new cases, it is still very helpful at identifying cancer before it becomes untreatable. So that's why cancer screening rates are important to increase. And so speaking of cancer screening rates, this map looks at the rate of breast cancer screening across the US. It's based on mammography usage on women ages 50 to 74 at the census tract level. The areas in light pink represent the lowest screening rates, as low as 54.3%. And on the other end of the spectrum, the dark purple is as high as 87.9%. And the national average is 76% for breast cancer screening. For cervical cancer, screening rates are based on herpes papillomavirus, HPV, and Pap smear tests on women ages 21 to 65, again per census tract. And you can see a bit more of an even distribution here on this one across the country. However, the range in rates is a bit greater, with the yellow as low as 40.4%, up to the dark blue at 91.6%. And the mean for cervical cancer screening is 81.6% nationwide. And then finally, for colon cancer screening, this rate is based primarily on fecal tests such as Cologuard and colonoscopies on adults aged 50 to 75 per census tract. And this one has quite a range, both in terms of percentages and distribution across the US. In the yellow, the lowest rates are as low as 33.2%, up to the dark red at 88%, and the mean is 68.6%. And you'll notice that a couple of states seem to be a little bit off in terms of their reporting, and that seems to be the case for states like Wisconsin and California, for instance. And this may be due to a variation in how these states reported cancer screening rates. And so this does affect the regression analysis that I did. So we'll come back to this. So you might be wondering, what are social determinants of health? Well, the World Health Organization defines them as the non-medical factors that affect health outcomes. And the US Department of Health and Human Services has created this nice graphic that breaks social determinants of health into 5 categories, including healthcare access and quality in red, education access and quality in the dark blue, economic stability in the light green, social and community context in yellow, and that would be things relating to the household composition, such as household size, female-headed household, the language spoken in the household, and such. And then in the light blue is neighborhood and built environment. This would be things like whether the neighborhood is predominantly has owner or renter occupied housing, internet access, and such. So the research question that I sought to answer in this project was, are social determinants of health useful in explaining variation in cancer screening rates across the contiguous US? And then if so, which set of SDOH measures are the most effective at explaining screening rates, and how does their influence vary geographically across the US? And so in order to answer these questions, I needed to collect some data. So I collected my data from two primary data sources. First, the American Community Survey is where I got a lot of the socio-demographic data. And this is collected on an annual basis through household surveys by the US Census Bureau. And then the other data set was from the PLACES, which stands for Population Level Analysis and Community Estimates, which are local model-based estimates of health measures coming from multiple data sources through the CDC. And both of these data sets were cross-sectional census tract level for the lower 48 states. So from these data sets, I was able to select a list of candidate variables to run in my for my regression analysis. And these primarily came from the American Community Survey, but some also came from PLACES. And they all correspond to the 5 categories of social determinants of health. So the ones in green, for instance, are related to or represent the economic stability category. And I'll also point out that HH stands for households as well. And I also selected 2 covariates, median age and non-Hispanic white percentage. And these were selected to account for any demographic bias caused by very old or young census tracts, or census tracts with very high or low minority percentages. So the first regression technique that I used was the ordinary least squares regression. And this is a global linear regression model. And since I had so many candidate variables, explanatory variables, I used the exploratory regression tool to calculate the best models for each type of cancer. And so for colon cancer, these 4 variables were selected by the model as being the best at explaining colon cancer. So public assistance, no health insurance, routine checkup, and non-Hispanic white were able to explain about 58% of the variation in colon cancer screening. Likewise, for cervical cancer, these 4 variables, average household size, English-speaking households, routine checkup, and median age, explained about 23% of the variation in cervical cancer screening. And then for breast cancer, just these 3 variables were selected. No internet, English-speaking household, and median age. And they, even though that was the best model, only explained about 3% of the variation in breast cancer. I'll also note that all 3 of these models did pass the model bias test and multicollinearity test, but none were able to pass the spatial autocorrelation test. And that indicates that there were some issues with model or residual clustering. And that is kind of illustrated in this map, which is looking at the OLS residual for colon cancer screening. Residuals are basically just over and under predictions by the model. So the areas in purple represent where the model over predicted colon cancer screening, whereas the green represents under predictions. You'll notice that in a lot of those states that looked off in the previous map, a lot of these had residual clustering, particularly Wisconsin, West Virginia, Oklahoma, California, where there was a lot of clustering of over predictions. And this is problematic because it prevents any models from being properly specified. However, I went ahead and moved on to geographic weighted regression just for colon cancer screening. And that was done with the assumption that the spatial autocorrelation was the result of non-stationarity, which I'll get to in just a second. So these maps, I mapped the coefficients for each of the explanatory variables in the model. And so on the left is the coefficient of public assistance in blue, and then the non-Hispanic white percentage in orange. And these coefficient values indicate how the relationship between colon cancer screening and the explanatory variable change geographically. And when the coefficients change sign, as both of these do, they change from negative to positive, that across the study area, that indicates non-stationarity or changing relationships. And so the areas with positive coefficients, which in these two maps are the darkest shade of color, the darkest blue and the darkest orange, these positive coefficients indicate a direct relationship between the explanatory variable and colon cancer screening, such that they both increase and decrease together. Whereas the negative coefficients, which are the rest of the colors on these two maps, indicate an inverse relationship between explanatory variable and colon cancer screening, such that they move in opposite directions. And then these were the other two variables. No health insurance on the left in green, and then routine checkup in the purple. I'll also mention that I used a quantile classification method here for these maps. And so that just basically means that there's roughly an equal number of census tracts or features in each class or for each color. And so that indicates that on the map on the left, that since 3 of the 4 categories are negative coefficients, that about 3/4 of the census tracts across the country have a inverse relationship when it comes to no health insurance and colon cancer screening. And this makes sense, as you would not expect an increase in uninsured people to correlate with an increase in colon cancer screening rates. And then on the right, similarly, 3 of the 4 are positive coefficients, so roughly 75% have a direct relationship here, which makes sense given that increased rates for routine checkups would generally correlate with an increase in colon cancer screening. And then finally, this map looks at the local R-squared for this model for colon cancer screening. And this basically shows the overall model performance across the study area. So the areas in the dark burnt orange color are where the R-squared is the highest, meaning the model performance is best at explaining colon cancer screening in those areas, whereas the light yellow is where the model is performing the weakest. And so certain regions, such as the Southwest, seem to have a high local R-squared, as do a lot of the urban and suburban areas, really all over the country. Those areas seem to have a higher R-squared than a lot of rural parts of the country. And so in conclusion, going back to the original research question, can social determinants of health help explain cancer screening rates in the US? Yes, they can, but it does depend on the type of cancer that you're looking at least with the variables that I selected. It did a very good job of explaining colon cancer screening, not as well for cervical cancer screening, and then really not at all for breast cancer screening. And so that may raise the question of why that would be. Why would it be good for colon cancer and not for breast cancer? And there are many possible explanations for this, but one possibility is that there are mobile units and mobile clinics that go out and screen women for breast cancer in poor areas and more rural areas, whereas colonoscopies generally require are generally done by a specialist, which you're not going to find in a rural health clinic, generally speaking. And in addition, colonoscopies generally require more prep, like fasting, and they're a longer procedure. So those are just a few possible explanations. Then which SDOH measures are the most effective at explaining the screening rates? I found that generally the variables from the economic, health, and social categories were the best. So from health, the health insurance and routine checkup were really important. From the economic, public assistance, and then from the social, some of these like English speaking households and household size were significant as well, as were the covariates, median age and non-Hispanic white. Median age, given that screening recommendations are generally based on age, it made sense that that would be significant. older census tracts are generally going to have higher screening rates than younger ones. And then for the non-Hispanic white, generally speaking, some of these lower screening rates are found in certain high minority areas, such as Native American reservations, for instance. And then finally, how does the model explanatory power vary across the country? I found that it was generally higher in urban and suburban areas than it was in rural areas. However, it was a bit dependent on the region. And this indicates that potentially the addition of like population density as a covariate for future analysis would be worthwhile, as it may help improve the explanatory power in rural areas. And these are my sources. Yeah, that concludes my presentation. Thank you very much.